In this module, we're going to go over examination for thoracic outlet syndrome. So if you guys remember, thoracic outlet syndrome is a condition where you get basically an entrapment of the nerve and blood vessel plexus that are leaving the neck and going in between the scalene muscles, the clavicle, and the first rib. So if there's any kind of tightening of this space, either with like a tumor or just muscle injury, muscle tightness, abnormal movement of the clavicle, even tight pec muscles, you can have someone that starts to have symptoms in their hands. Typical symptoms are going to be numbness in their hands, tingling in their hands. They may even have weakness in their hands. They may notice their grip strength is impacted. And a typical thing is that their symptoms comes and goes, and it could be triggered by certain activities, whether like being on a computer or doing a certain sporting event or physical movement in the gym where they notice their hand numbness is getting worse. So anytime you have a specific movement or a specific position that's causing symptoms, it's very likely that it's not really nerve injury, but typically things that are causing compression based on the movement they're in. So we'll go over thoracic outlet syndrome. It's one of the most common misdiagnoses you'll see out there. When people have numbness in their hands, everyone's just immediately thinking nerve, and many times it's really this vascular compression that's causing their patterns. Okay, so with thoracic outlet syndrome, they basically, you're looking at some kind of entrapment. So if they have any kind of numbness or tingling or weakness in their hands, there's a possibility that there could be an entrapment. The brachial plexus and the brachial artery and veins, they're going through the scalene muscles, and they go on top of the first rib and clavicle. So through this space is where you can get some degree of entrapment. And if there's entrapment in that space, and it's usually to the blood vessels, the symptoms are going to present in the hands and not so much in the shoulders or in the forearms, but weakness and throbbing and even discoloration in the hands. So the basic tests that people use and the conventional orthopedic tests that are used are not always that great. The Ruse test is basically a test where you have someone bring their arms into this position here and then extend past the shoulder. And here what we're doing is we're narrowing the space between the scalenes and the first rib, and you have them close and open their hands for 3 minutes. And they will constantly do this. And if they have any symptoms during this test, like throbbing in their hands or weakness in their hands, then that would be a positive test. Now, it's very subjective, and sometimes people will go through this and just get fatigued way before they have any kind of symptoms, but this is the conventional Ruse test, and this is the one with the highest degree of specificity and sensitivity. It's in the 70-80%, but it's a test that's used. The key thing with thoracic outlet syndrome is actually entrapments can really occur in 3 places. One of them is the scalenes, and then the other one is the clavicle that's moving abnormal, or even a very tight pec minor that can cause some contractions there. So a lot of times, if you see a patient that complains to you that their hands are getting numb, if their head is flexed, like they're reading when they're on the computer, that's usually these scalenes that are causing that type of compression. Okay, and if they're reaching across, and that's when they notice symptoms in their history, then it's typically a tight pec minor. And these are pretty easy. You can just go in there and just kind of palpate. If they have symptoms on the right side, you can palpate like the pec minor, and if they have lots of trigger points and it's tender, that can be an indication. And then same with the scalenes, you can just go underneath here and just palpate the muscles. It's better to kind of flex the person's head forward and then palpate and see if they're really tender in there or not. And that can give you a clue of those patterns. And the costoclavicular one is when the clavicle is moving abnormal. So if they get symptoms when they're reaching out or reaching back, then that's really more of a costoclavicular type of pattern. Now the conventional orthopedic tests that are done is like checking someone's pulse and putting them in provoked positions to see if the pulse changes. The reliability of all those testing are very poor. It's very hard to feel pulse change just by putting a person in a different position and having them take breaths. Reproduction of symptoms is really one of the most efficient ways. Now, one of the other things that'll happen is when there's compression, you do just get general weakness of muscles of the hand and fingers. So you can sometimes just like check finger strength. Go ahead and resist. Or you can check something that's like just even wrist strength and just hold this tight. And then to test like an anterior scalene entrapment, you have a person rotate, bring their head into flexion, and really contract those scalenes. Take a deep breath in, and then you have them hold those muscles and See if there's any kind of weakness that takes place. And if that does, that lets you know that you have an entrapment there. And sometimes you can just have symptoms provoke when it's coming from those anterior scalenes. And in those cases, they're usually spending way too much time with the neck flexed and kind of anterior tilted like that, where these scalene muscles are contracting, and they have to avoid those habits, and then you have to get in there and strip these muscles out. For people that have a costoclavicular pattern, their pec minor is really what's causing the entrapment. So again, you can like bring their arms across and just see if their muscle strength changes in these patterns. You can also, if you wanted to, check the pulse. And if you see any kind of symptom change, well, the pec muscle is contracting, then you know you have pec minor syndrome, and they have to really avoid work or positions where their arms are flexed like this all the time. They can like put their arm against the door and stretch that muscle and strip it, and that'll get rid of the entrapment. The more complicated one is the costoclavicular one, and that's when this clavicle is rotating abnormally back. And that happens because the subclavius muscle sometimes gets strained or injured there when people do heavy lifting or move an object above their head. So you can check the pulse, or you can just check a muscle. Like here we can test wrist extension, and then the best thing to do is hold this tight and just bring the muscle all the way back, and now we're closing that space up. That clavicle will bring this back and then resist. And if this is causing any kind of symptoms or any patterns, then you know that this subclavius muscle that's running the clavicle is pretty tight, and you can release that and just work that out. And then avoid positions where they're lifting with their hands and moving things aggressively for a period of time. So there's some really practical tests you can use to find different types of TOS patterns. Okay, so when you look at the specificity, sensitivity of the different orthopedic tests for thoracic outlet syndrome, they're all pretty bad. The only one that's somewhat okay is this Roos test, where you have one person do this for a period of time for 3 minutes to see if they have any kind of symptoms. Adson's test and Wright's test, for just checking for the pulse in different positions to see if it goes away, is really not a reliable test. So you're really left with these orthopedic tests that are classically done that really don't have a lot of good specificity or sensitivity. A lot of times just putting a person in a position that can provoke their symptoms is a better way to look at it, or if a patient has noticed any kind of numbness. So the three main types of thoracic outlet syndrome, functional compartment compressing patterns, or tightness of the scalene muscles, tightening of the pec minor muscle that just moves the clavicle forward and shortens up that space, or if someone is having any issues with their subclavius muscle or their clavicle is tracking wrong. Now, obviously, for those are all functional. Non-functional would be like there's a space-occupying tumor or some kind of compression there, which is pretty rare. But usually what you'll see with people that have a scalene syndrome pattern is just that tightness in their scalenes, putting their head in this kind of position or doing movements like this is really where their symptoms come on. And typically history is the best way to identify it. You can basically strip those muscles and see if they go away. Sometimes just putting them in this position and really contracting those scalene muscles can recreate their hand numbness. And if you test for muscle weakness, you can sometimes just see any muscle you're testing in the hand, whichever nerve root distribution you want to use, is going to be weak in a provoked position. The pec minor one, you really want to bring the arm all the way across and really contract that pec minor, see if there's any weakness there. That's really the key thing with that. And people that have the shoulders rolled forward all the time, people that use a laptop and type like this all the time instead of using a normal desktop computer, will typically get these costoclavicular, these pec minor type entrapments. And then sometimes people will strain their subclavius muscle. The subclavius muscle attaches to the clavicle, and it rotates it as you move your arm into abduction, as you elevate your arm. And sometimes when people are lifting something really heavy, they'll strain that muscle, and then that muscle becomes inefficient. So every time they try to move, their clavicle doesn't move appropriately. That space gets compromised, and they can get some symptoms. And your biggest indication of this is a history where they lift their arm up and their symptoms are getting worse, or they have done activities where their arms are elevated or reaching back. And in those cases, you want to get in there and really look at that costoclavicular and strip it. Now, sometimes just looking at their history, working on these muscles, can save a lot of time. I've seen many patients that have thoracic outlet syndrome that have spent thousands of dollars on imaging studies, nerve conduction velocity, EMG studies, that really should have never been done. Concerns about undiagnosed, like diagnosable conditions like multiple sclerosis that sometimes occur with people that don't know what they're doing, that evaluate them. So the best test is really to see if provocation makes their symptoms worse, changes any pattern of muscle strength with them, treatment, and then resolution of symptoms. That's how you really know the diagnosis was accurate.